Good afternoon and welcome to HL7 Da Vinci Community Roundtable. Today's session is Accelerating Adoption, Clinical Advisory Council Insights. My name is Alix Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. Today's session focuses on clinician perspectives as organizations seek to modernize healthcare workflows by leveraging automation enabled by FHIR to achieve greater efficiencies in providing patient care. Through technology-enabled data exchange and data harnessing capabilities of both provider and payer systems, the right data at the right time for the right patient and fit for purpose can be enabled. Various federal and state policies, as well as industry's needs to extend human capacities, have been at play for quite some time. Our nation has been iteratively improving data capabilities as reflected by private sector innovation, standards development initiatives, and policies from Congress, state legislatures, and federal agencies. More approximately, CMS 0057 is a major influencer at play right now, as well as CMS's 9115 rule and ASTP or ONC's electronic health information policies spanning the United States Core Data for Interoperability, Health Data, Technology, and Interoperability, referred to as HTI, as well as information blocking regulations, to cite just a few. It was great to see this week's announcement of health insurers pledging 6 key reforms aimed at cutting red tape, accelerating care decisions, and enhancing transparency for patients and providers. And this goes beyond streamlining and improving prior authorization processes for Medicare Advantage, Medicaid managed care, and health insurance marketplace, as it includes commercial plans representing coverage of nearly 8 out of 10 Americans. The Da Vinci Project, since its inception, has sought to keep the clinician care setting at the forefront, meaning that patient and provider interaction and related care delivery as the focal point. This Da Vinci structure includes a Clinical Advisory Council, or CAC. The Clinical Advisory Council's mission is to provide a strategic clinical insight and guidance to the Da Vinci Steering Committee and Program Management Office to ensure program outputs stay aligned with goals of reducing administrative burden, improving transparency, and simplifying access to and use of critical data and workflow for providers and payers to satisfy regulatory requirements and improve patient outcomes. Key to the Council's role is to ensure that pragmatism and real-world experience is applied to priorities, strategies, and decision-making processes across Da Vinci's outputs. Starting last fall, the CAC discussed implementation barriers facing providers and adoption strategies and considerations regarding how to accelerate adoption by providers. The insights and recommendation categories will be presented today by Stephen Waldren, providing an in-depth overview of the CAC's insights. Following the overview, we'll launch a poll to ask you a few questions. Then we'll have a fireside chat with Dr. Waldren as well as Dr. Julia Skapik to ask questions I've teed up and the ones you'll post in the Q&A Zoom feature throughout today's meeting. Both Stephen and Julia sit on the CAC and hold diverse roles in industry, with primary affiliation for Dr. Waldren with AAFP and for Dr. Skapik, Julia, with PurpleLab. We're very grateful for Stephen's leadership as well of the CAC. I encourage you to use the question function in the Zoom platform today to submit your questions. Additionally, I want to just note that lines are muted to aid recording quality and that we'll use that Q&A feature as chat has been disabled. And please, at the end of the survey, or at the end of the webinar, please please take a few moments to complete our survey. It really does help us with future programming. For upcoming community roundtable schedule, I want to just make sure that folks are aware that not only will we post today's webinar and slide on the video presentation page, but you can also find prior sessions on our video recording page. The link is available on the slide, and I'm sure Leslie will also be adding that into the chat for everyone today, as she'll continue to provide us with various helpful hints on today's recording event. Sorry, I'm just looking out there and am I not sharing my screen? I think I've just found that out. All right, I am sharing my screen.
You are sharing your screen.
All right, so I'm sorry, I'm just seeing some chat button posts coming in, and I just wanted to make sure that I wasn't missing anything, so I apologize for that slight distraction there, folks. But for the community roundtable sessions, we do have our prior events webinars recorded and posted along with the slides, and we'll do that same for today's event, and that we hope that you will also take note that we will take a hiatus in July. We're not going to have a meeting in a community roundtable. We will resume our community roundtable on August 27th at 4 p.m. Stay tuned for more details. We'll get those pushed out through the listserv and also posted to Confluence on our calendar. All right. So a few other things that we want to make sure that you're aware of are some upcoming events. WEDI is going to have a very busy summer. They're having a session to, I believe it's tomorrow, on the road to 0057F readiness, digitizing prior authorization policies for health plans is the focus for tomorrow. And then they'll be having a summer forum that'll be held in Chicago. I think this may be a hybrid event, but don't hold me to that. It's August 5th and 6th. So if you're going to do in person, that'll be in Chicago. HL7 events include the typical summer CMS and HL7 FHIR Connect-a-thon. This is an all virtual event, July 15th and 17th. If you are interested in this free event, you better register because they're going to cap it out at 1,500 people and they're getting close. And registration, I know, formally closes at the 30th. So please make sure to jump on that link as soon as possible if you haven't already registered. The CMS event Connect-a-thon includes a day of policy, programmatic updates from our federal partners, as well as lots of opportunities related to testing and observing Connect-a-thon deep dives into the implementation guides included in the Connect-a-thon. This coming September, and you can already register for it, the 39th Annual Plenary and Working Group Meeting and HL7 FHIR Connect-a-thon. We encourage you to join us in Pittsburgh, Pennsylvania, September 13th through the 19th, and hope to see you there, as they'll have a half-day plenary on Monday, followed by a number of educational opportunities, and as well as the working group meeting, and all of that Monday through Friday working group meeting is preceded by a weekend Connect-a-thon testing event. All right. I'd like to now dive into some program updates for everyone related to recent implementation guide publications and also some updates on our piloting efforts. First, I'm going to run down the IG publications. So there are 5 of them that I want to showcase today. Help you understand that the unsolicited notifications implementation guide STU 1.1 was published in April. This implementation guide describes a method for communication of relevant notifications to support real-time exchange of information that impacts patient care and value-based or risk-based services. This may be as traditional as notification of an admission, discharge, transfer from a care setting, but it can also include notifications about changes in treatment, such as new or different medications, or changes in the patient's status, like a new diagnosis. These notifications provide information that can improve care management and care coordination, as well as act as a trigger for quality programs and other patient-focused activities, such as risk adjustment. A few of the changes to note here that they expanded support for the United States Core 6.10 and 7.00. That tracks with United States Core Data for Interoperability trajectory under HTI rules. There's also a new cross-mapping between the direct ADT message elements and the Da Vinci notification ADT message bundle. So further industry alignment and coordination there with direct. There's also changes to the menu bar and some other features within the implementation guide. And the implementers submitted multiple trackers related to the publication of version 1.0 of this implementation guide, and those have been addressed. And in each of our implementation guides, there is a changelog, so you can take a look at the changelog, which is one of the menu options at the top of an implementation guide. So if you click on the link in these slides, you'll get directly to the implementation guide, and you can then unpack the changelog if you're looking to dive deeper than the overview that I'm going to give you on these implementation guides today. From a postable remit perspective, this was published in April, and the postable remit implementation guide, this is the first balloted publication. It defines a standardized method for healthcare providers to electronically request and receive duplicates of an originally transmitted remittance advice, which are explanations of payments from insurance payers. Currently, providers often rely on inefficient and time-consuming methods to retrieve duplicates like payer portals, phone calls, faxes to obtain these documents. And this implementation guide, Postable Remit, enables providers to search for remittances based on criteria such as claims information, patient details, and payment data, and that payers can then download the remittance electronically, typically as an X12 835 compliant remittance advice document or a PDF. And that this, hopefully this implementation guide provides a solution in the marketplace for streamlining the duplicate retrieval processes, potentially reducing manual efforts and improving efficiency for the healthcare providers in posting their payments. The next implementation guide I wanted to touch upon was member attribution, which we affectionately refer to as ATR in short for attribution. This is a published implementation guide upgrade to STU 2.1, and this ATR lists that are produced are used between payers and providers for implementing risk-based contracts, value-based contracts, care gap closures, and quality reporting. The purpose of the IG is to define mechanisms, data structures, and value sets to be used in exchanging the member attribution list. And member attribution typically contains, the changes in this implementation guide from STU2 to 2.1 includes modifications to support various US core versions such as 3.1.1 and 7.0. It also updated the attribution list status codes to include a status of open in support of CMS 0057 payer data exchange and provider access API implementations. Corrected some typos, enhanced the overall navigation of the IG, and also removed custom group search parameters as it's now present in the base resource. Just some highlights of the changes on member attribution. Data exchange for quality measures is now at STU 5. This was published in May 2025, and this implementation guide defines a framework to support quality measurement, reporting, and related use cases, enabling the following capabilities: the reporting of quality measurement results with or without the data involved in calculating those results, and the definition and exchange of data of interest for a measure or a set of measures. And this implementation guide builds on a lot of prior work from US Core, QI Core, and QRDA Category 1 and 3. For those of you deep into quality, I'm sure you're tracking with my QRDA reference. This was initially supported by the Vinci project, and we have handed it off for long-term support to the clinical quality information and clinical decision support work groups. But we're clearly tracking these implementation guide progress as it's pretty critical one in the marketplace as quality and digitizing the quality measures is getting more traction and evolution. So I encourage you to take a look at this IG as there are a ton of updates spelled out in the changelog. The final implementation guide I want to make you aware of is the PDEX implementation guide, SDU 2.1. This was just published about a week and a half ago in June of 2025. And the PDEX, as we call it in shorthand for Payer Data Exchange, aims to improve how health insurance companies share patient data, and it focuses on three main scenarios: sharing data with healthcare providers, transferring information when patients switch insurance plans, and allowing patients to access their health data through authorized apps. And so this really helps with exchanging members for exchanging information, such as clinical information and prior authorization information. This implementation guide also allows payers and providers to receive claims and encounter information without monetary value points. And it is recommended in the 0057 regulation, as we all know, for Medicare Advantage plans, state Medicaid agencies, and individual qualified health plans to provide the standard API for easier access of information to benefit health plan members. Tons of changes happening there and very well detailed in the changelog. On the piloting front, the Trebuchet project will be holding its next meeting on June 26th. The next public call after that is not until August 7th, and that will then begin an every 2-week meeting occurrence for the Trebuchet community. You can dive into their meeting minutes and catch up with more details on the available Confluence page noted here on the slides. And also, we are leaning more heavily now into the patient cost transparency. There's actually participants meeting now regularly every 2 weeks on Mondays at 1 p.m. Eastern. You can check out the Confluence page for the PCT piloting effort, and you can also reach out to us at the Da Vinci Project if you're interested in getting involved. My last slide, I think, is to make sure that you're all aware that the requests for information, or RFIs, from our federal colleagues, a number of them have been responded to within the Da Vinci Project and community. We have posted the responses that we've submitted to our industry statements and updates a section of our homepage on Confluence. You can get the link generally to there on the page on the slide, but you can also get the 3 specific responses. We've posted those URLs as well to our response to the health technology ecosystem RFI, the deregulation of the Medicare program opportunity, as well as our focus on modernizing digital quality response to the 2026 hospital IPPS and long-term care prospective payment system proposed rule. So Da Vinci members work collaboratively to focus on responses that are directly germane to the Da Vinci Project as a whole. So with that said, I would like to invite Dr. Stephen Waldren. Thank you, Steve, for coming on screen. And I'm going to now turn it over to Steve, and I'm going to run his slides so that he can give you an in-depth overview of the Clinical Advisory Council's insight work.
Thanks, Alix. Appreciate it. So for those that are not initiated with the Clinical Advisory Council, Alix kind of talked a little bit about that before she did the industry updates. But again, the intent here is for this council, which represents 12 individuals with 2 co-chairs. So I co-chair this council with Ed Yu from Sutter Health, who's also a primary care family physician. And we have, of those 12 members, we have primary care physicians, we have specialist physicians, we have nurses, we have pharmacists that participate in this council. And the intent here is that we know that we get a lot of feedback from kind of frontline physicians and clinicians in a lot of the work groups around the IGs, but the Da Vinci wanted to make sure that there was this formalism that allowed the advisory council to give direct feedback kind of from a strategy standpoint back into the steering committee. And we've been working on that for almost 2 years now, providing kind of that feedback. And in late fall of last year, the committee came together and said, you know, we like to see how the advancements are happening on kind of Trebuchet and some of the pilots. But we'd love to figure out how can we kind of accelerate, or what are some of the barriers to accelerating the adoption of these IGs by provider organizations. So we set out a project where we brought in some innovators that were already implementing some of the IGs, especially around kind of prior authorization, which is what providers are really caring about a lot. And we had them talk to us about kind of their successes and challenges, and what their thoughts were on kind of improving the process to drive adoption of the IGs. And then we had a detailed conversation amongst ourselves to try to identify what were some of those barriers that providers were facing, and what are some adoption strategies that we could use to really drive some of those barriers out of the marketplace with the intent of accelerating the adoption of that. So we are publishing a document that has a listing of the barriers that are in each of these categories, and we'll walk through those here in just a second. But in addition to that, we also put together a set of strategies here on the right, or we think there are opportunities for not just Da Vinci, but really the entire ecosystem to really help drive the adoption of these solutions. So again, when we talked about kind of these strategies, we're thinking about these are just Da Vinci strategies, but rather these are community strategies, and some of this Da Vinci will pick up others, will need others inside the ecosystem to pick up. And we'll talk a little bit about those in more depth. And before we go to the next slide, I would say that we try to put all the recommendations on the slide. So I won't have time to go through all of them. I'll give you kind of a synopsis of each of these categories, but you'll see a lot of words on the screen, so you can take these back with you and dig a little bit deeper into the barriers and the recommendations. So Alex, if we go to the next slide, we'll start talking a little bit about kind of the limited resources that are available. And we thought this was a huge challenge. So in general, there's a really lack of resources and really technical competency. So even if you have the capital to fund, which a lot of organizations don't, it's hard to find the right individuals to be able to support them in doing that. And for a lot of them, especially the smaller practices, they're going to either depend completely on their EMR, or they're going to have to hire intermediaries, which are going to be an additional cost for them to be able to help them implement these IGs inside their organizations. And we're really concerned too about the potential of low resource organizations and creating kind of a digital divide. So is there some opportunities to support them both financially and technologically from an expertise standpoint to really drive adoption of these IGs into the marketplace and make sure that we don't have that digital divide, or at least a further digital divide than we currently have. So that's the notion of kind of limited resources. So on the next page, we'll talk a little bit more about kind of the manual workflow and the organizational readiness. And in the manual process, I think one of the big things that we talked about is that even if each individual payer puts together a nice workflow that maybe is using their portal, I know in family medicine, our docs see about 7 to 10 payers in their marketplaces. So you have 7 to 10 different portals now that you're going to have to log into, and they're all going to be slightly different. So it still requires kind of a manual process, even when you think about the amount of investment and the thought that went into creating these type of portals. But also that there's a lot of kind of older technology that our members are using, or physicians are using, or practices are using, that they just don't have the ability to upgrade to these new IGs. And they're really dependent upon those technologies to be able to be upgraded. So I think there's a real need to really drive adoption in the EMR kind of community. And then on the organizational readiness, we felt like too, maybe the clinicians are ready to move forward, but the organization has a lot of competing priorities out there. Transition to value-based care, supporting some of the changes that are happening through the current administration, and they just don't have the ability to focus on the use cases that are really important, or maybe the use cases that are the most mature currently in the IG portfolio of Da Vinci. And then I think there's also still a lack of awareness. We'll talk about it here as in regards to kind of the executive leadership, but understanding of kind of where the IGs are at, how they can be implemented, and really what's the value proposition for these organizations, what type of return on investment can they depend upon if they actually implement these types of pieces, and then also who are the other partners on the other side of the interchange that have already implemented this that they can work with if they do adopt these type of IGs. So we talked about a lot of those kind of organizational readiness pieces that are going to be important as well. If we move to the next slide, we'll talk a little bit more about what the community readiness is. And we talked about that too, is there really being able to understand, as I mentioned before, who is implementing these IGs and where everybody's at, so that you know kind of who to go after and try to partner with. And that there's really a lack of kind of education around kind of issues around FHIR, and is that more risky than doing the more traditional kind of consolidated clinical data architecture exchanges? And if they have access to my APIs, what can they use the data for? Is it just for payment and operations or treatment, or can they use that type of data to try to figure out, should I be part of the network as a provider organization for a payer? So I think there's some concerns around that kind of readiness as well. And then again, the fact that there's not really big dominant payers, even Medicare and Medicaid, it makes it difficult to adopt, because you get some economies of scale, of course, with multiple payers implementing these. But if you have only one or two, you still have, again, in family medicine, somewhere between 5 to 8 that you still have to do some manual process on. So you still have the burden to doing those exchanges in a more manual process. So if we go to the next slide here. A lot of conversation around data governance and standardization. We realize that we've made a lot of progress in this space over the last many years, but there's still a lot of work that needs to be done around views of data, and especially as it relates to what data is needed for value-based care, and that making sure that that the standardization is not hindering the ability of providers and payers to create efficient care solutions. We talked about fragmentation of data. So even if you have some folks, using FHIR, others may be using CDA, CCDs, and others may require some older, version 2 type of exchange. And then we did talk a little bit about the notions around privacy, which I mentioned a little bit briefly around that. But there's also issues around patient data too, around reproductive data, which has become more sensitive in the last a year or two, and making sure that FHIR is able to be data specific and be flexible enough to protect that type of data. So again, there's still a lot of work that's already been done on the standardizations, but we still have a fair amount to kind of go relative to that. And I see this as an opportunity for Vinci to continue with its developments around the IGs. And if we go to the next slide, we can talk a little bit about the EMRs. I think the biggest thing for me relates to the EMRs is that the majority of medium and small size practices are going to be completely dependent upon their EMR. If their EMR does not implement these IGs and implement them in ways that make it so that there's a seamless kind of clinical workflow, then these practices are going to struggle. Either they're not going to be able to participate in exchanges, or they'll be able to participate in exchange, but they'll still have a kind of a burdensome process on the kind of user experience piece as it relates to their clinical integration of those functionalities inside their EMRs. So again, I think we really need to have our EMR companies help us adopt these IGs so that we can get to those smaller and medium-sized practices, in addition to make it easier for the larger practices and hospital systems to adopt these types of IGs. And if we can go to the next slide here, please. So there was a couple of things here that kind of didn't fit into those. So we did talk a little bit about kind of TEFCA and, well, what does that mean and how does that work? And does it delay things because we're trying to figure out how that works as opposed to just implementing the IGs in a more traditional manner? Or does that help us really drive wide scale adoption of that? And as a group, we weren't quite sure what the path forward that was the most beneficial, but we do know that we need to figure out how those two things can work together. And then the last one that we talked about is just the variability and uniqueness inside of healthcare. And we all know this, and no matter, even if we're talking about technology or kind of standards of care even, there's a lot of one-off solutions. And if you've seen one hospital or one EMR or one practice, the saying is always that you've just seen one of those organizations. So being able to scale that across the whole community and the nation is going to be a real big challenge. Even if we can solve the problem, individually with a particular EMR, you still have this notion of the different implementations that may have happened across the U.S. So So those are the barriers. And if we go to the next slide, we'll start talking about, well, what can we be done to try to support those barriers? And again, I want to emphasize that while, Da Vinci will be looking at these and strategically figuring out how they can help drive some of these opportunities, that these opportunities are not designed or put out just for Da Vinci. This is more put out from a perspective of the entire community. So we talked about being able to make sure that there's nice demos to show people the value proposition and really get them to understand how these things kind of can work in the education space. We also talked about being able to make sure that we understood how kind of each individual EMR had implemented some of these IGs and how best could those users use those EMRs to drive adoption at the bedside. We already talked about the TEFCA piece, but we think there's also really an opportunity to really educate the provider organizations on kind of awareness building of where the IGs are at and then which ones are ready to be implemented inside the organizations, but also what are some real world impacts that these IGs have had on practices. We had a great chance to talk with those early adopters talking about some of the like attribution and other things that just being able to implement those had a significant financial and burden reduction impact on their organization. So I think being able to make sure that people understand those and see that those are actually real, not just theoretical advantages of implementing these. So again, I think the provider kind of organization education is really, really an important piece. Next slide, please. So just some additional ones, and I would say here, in addition to kind of the provider education, I think there's also kind of a policy maker and administrator education need as well. But again, we talked here about kind of ROI and some of those things that are really needed to better understand so that people want to be able to take the risk of implementing these types of IGs in their organization. If we can go to the next slide, please. So just again, a lot of education. So we think that's one of the biggest opportunities and maybe one of the least heavy lifts for the community to be able to drive. But it really needs to make sure that people understand not only awareness, but what the actual impact is and how you actually go about implementing these in a working real world solution. Next slide, please. So we talked about this notion of being able to make sure that we had the right measures, because we think there's also not a really great set of measures to say like, well, here's the measurement that you would do to show that you got the ROI of these implementation guides. So I think there's an opportunity there to help support organizations to understand how best to evaluate the implementation of these IGs. And then we did talk about being able to do a lot of more piloting and case study work. So not only just pilot and say it works, but actually create the case studies from those to drive the kind of, again, that education component of what the outcomes really are. And make sure that we're actually collecting what are the best practices. So can we be able to create those as we create the pilots and then disseminate those out through education. And the next slide, please. So the other thing we talked about is about just really supporting the individual organizations, the provider organizations that are implementing these types of IGs. So we talked about, is there an opportunity to create kind of an implementation network or a learning collaborative? So, everybody's not learning the same thing in their own organizations, but can share learnings. Is there an opportunity to really be able to understand what are those best practices? To really working with the EMR and the third-party intermediaries that they'd be working with. And how do you really give the experience of those early adopters? And is it an opportunity to create some type of, softer guides to show how you would actually implement the implementation guide, so to speak? So those are some of the things that we talked about as it relates to kind of provider implementation support. We did talk about also being able to support kind of the financial pieces of that, but I think it's more than just that financial piece. Again, like I said, with the resources, they don't have the technical expertise to be able to understand how to do this well. So how can we help support them to do that well? Next slide, please. I think we're getting pretty close to the end here. So we did talk a little bit about kind of certification and advocacy. So again, I think we still need to be able to support that advocacy and really drive these standards and implementation guides into policy, either that be payer policy, provider policy, or federal policy or state policy. But once we know that these things truly work in the real world, making sure that we can lever that advocacy to continue to drive wide scale adoption across the industry. We also did talk about, need for kind of maybe potentially some more additional certification, again, to know that your implementation of that it works, because a lot of provider organizations are not going to be able to know that. But if there's some third party that could help them make sure that this is a good implementation of the IG, that could be helpful for them to reduce their perceived risk of adopting the IGs. And then we did talk about trying to help provide payer kind of organizations as it relates to kind of standardizing payer content. So as much as possible, can we maybe even standardize what it means to have a diabetic patient, as example? I hear from my docs that that definition sometimes changes across different payers. So how can we really drive that in a way that makes sense for the payer community and also reduces their burdens? And then we did talk about this notion of privacy, both the privacy of the individual patients, but also the provider organizations. If you're giving greater access through APIs to more and more data that's inside the EMR, what are the rules around how to use that particular data or not use that particular data? And I think that might be it, but let's see if there's one more category that I missed. Okay, I was right on my money here. So one thing that we did want to do is kind of pull you guys to get a sense of kind of where you guys are at, and also to get some of your feedback on some of these issues around kind of burdens and opportunities. So I think Leslie's going to push up a poll here in just a minute that should pop up on your screen, and we'd hope you take a few minutes or a minute or so to answer those questions for us. So we'd appreciate it very much.
Great job. Thank you, Stephen, for giving us that in-depth overview. Grateful for everyone to take the couple minutes here and answer the polling questions. That'll also give us another minute or two to get our other participant to be able to join us. We know that Julia's in back-to-back meetings today, so I'm trying to communicate with her separately on when she may be able to arrive. So once we get to give everybody ample time to review that survey, we will share the results and talk about it for a little bit. There she is. Hey, Julia. Welcome. We are in a polling status at the moment, so perfect timing. And it looks like some folks are entering something into the chat box, but hopefully you could actually complete the survey unless there's some technical challenge you're encountering, you can let us know that. So we're just about 37% responses in, so hopefully we can get a little bit higher for everyone's responses before we call the question on that. Okay, let's see if we can get over 50%. Let's give it a little more time. And somebody has just pointed out that we do not have provider on the survey, and they are absolutely right. That was supposed to be one of the menu options, and appears to have been an oversight on our part or a typo, because it was there in the demo practice earlier this week. I don't know, can we add that in on the fly, Leslie, or are we too far into this yet to be able to do it? And my apologies for that typo or error on our part. Okay, we are over 50%. So I'm thinking, Stephen, what do you think? We should call the question and the poll?
Sure.
Okay. All right, Leslie, are you able to? All right, she's sharing the results. Awesome. Thank you so very much. So we're gonna just kind of do this all on the fly, folks. Each of us should be able to see the polling results on our own devices. Because of the way it's set up, we're gonna have to do it that way. We'll keep the questions showing. So we don't really know the true breakdown because we don't have the provider list. So maybe they've added that into the other category and we can take a look at that. But we do have an interesting blend today, vendor and others being the majority of folks on the call. With about 14% of payers also on the call. I suspect the other category is higher because we have providers that are self-identifying there due to our error. So the second question related to, are you using any of the current workflows or data sharing capabilities, FHIR-based? And we've got 57% saying yes, 36% saying no, and 7% are not sure. But that's really great to see the impact that FHIR is having. I suspect that's probably going back to the federal regs 9115. But I'll be curious to see what we can learn in the prior authorization. Any comments, Stephen, before I keep scrolling on?
No, I mean, I would assume that this is the group of, or the community that's going to be adopting these, but I still think, 57, and then I see in the prior auth on question 3, 58 saying yes, I think is really reassuring. And again, as I talked about the need for education, the fact that only 7% are unsure, I think is wonderful to see.
It's actually way higher than I was expecting, especially when we consider the results of the Weedy survey showed so little adoption. Just jump in, Julia.
Okay. Yeah, I was gonna say, I think it would be interesting if we had a method to sort of dive more deeply into what constitutes electronic prior auth, because I'm personally very excited about the extensibility of the functionality that's described in TMS 0057F as compared to the thing that is currently offered in my electronic health record in my primary care clinic. So in my primary care clinic, there is a thing called electronic prior authorization, but it doesn't interact with me at all. It will just send out a message to the payer and I don't get a response back right away. So it doesn't really meet the spirit or the intent of what the full electronic prior authorization will enable. So I wonder if some of the folks, and maybe people just want to jump in and give us a little more detail on the line here, what that spectrum is like of implementation. Does it go all the way to sort of that live bidirectional exchange based on the coverage requirement documents and allow you to do that documentation necessary in the interface? Or is it something maybe a little more lightweight than that that doesn't quite get all the way there? Yes, they can communicate in the chat. Thank you.
Yeah, and the Q&A, yes. So if people have extra thoughts that they want to give us, they can certainly drop those into the Q&A box. Some better adoption than I was expecting. And then the fourth question was, have you encountered concerns? And I am really surprised that we have a 50-50 split on concerns with implementing EPA. And I'm really glad that we provided the if yes, what concerns have you had? And this gives folks the way to look at those answers. However, I'm not able to see them. So maybe Leslie's able to see them, and that we can tap into that information as we move forward. She might be able to share that with us separately. She may have access to that directly.
Yeah, I can say, Alix, I spoke to folks at the AMA national meeting about this month, and I think there's a couple different sets of concerns. One of those are really around how that workflow will be effective or not in in the process of regular care activities. But I think there's another sort of legitimate concern there, which is that is making prior authorization easier as a process going to mean that there are more prior authorizations, so that basically we lose that benefit of the burden reduction by increasing the total volume of prior authorizations. And I've heard a number of physicians express that concern. I think it is somewhat a positive step that this week, the administration announced that they'd be voluntarily partnering with payers to try and make prior authorization less burdensome, sort of as a big activity, and reinforcing that commitment to electronic prior authorization. But I think I could see people who are, fairly confident in being able to do electronic prior auth, but have that concern that they're going to have to do 3 times as many of them in the future.
Well, and I think that that's a really, I'm glad that you brought up the work that the presentation and collaboration that you took on for the Da Vinci project with the AMA at the beginning of the month, and because we're really trying to foster more dialogue. And at that point, to that point, what I'd like to do is weave in a question that we got from the audience, because you started to tiptoe into it, Julia, as well as I noted at the beginning of the call in my introduction about the pledge that has come out, and that we have a question that's asking for your view on the recent statement from AHIP and CMS about the voluntary adoption of processes to reduce the burden of prior auth. And one of the things that I think is important is that with the coverage requirements discovery call, FHIR API call, you can actually get the answer really quickly. And you could, in a large degree, I believe, with the HIPAA exception process, we found well north of 3/4 of the responses was one wasn't needed or you're good to go, which really will then reduce the volume of prior authorizations that are actually needed to be processed. But I think that for me, the fact that the commercial payers are signing up, not just the CMS regulated payers, was really great. And I think it bolsters the industry, the support for 0057. But curious, Stephen and Julia, how you're viewing that recent statement and pledge.
Yeah, well, I'd happy to start. I mean, I think it is great to see both the private and public sector payers get together and say they're going to work together to do this. As I mentioned in my comments, from an AFP perspective, we see 7 to 10 up to 14 different payers. So that, I think, makes a whole lot of sense. So we'd love to see that. I think for a lot of physicians, the proof is in the pudding. So actually, what does that truly mean? What are they going to do? And when is it going to get accomplished? What is going to be available? So, we have not necessarily concerns, but, I think a lot of physicians have felt like people have said things in the past that they're going to do. And then when it gets implemented, as Julie was talking about, well, prior auth is implemented, but it's not bi-directional. It's not integrated into the workflow. So it really doesn't get to the point that it actually benefits the frontline clinician. So that would be my big concern. But I'm really excited about the fact that, again, that there's a large group of payers coming together to work on this, because I think that's what's needed, not just individuals, payers working on these type of problems. So but I'd love Julie's thoughts on that.
Yeah, I mean, I have to wholeheartedly agree with you. Industry pledge to execute on a promise or program voluntarily is clearly does not have as many teeth as a formal requirement. And even a formal requirement doesn't have that many teeth unless there's an enforcement mechanism. That being said, one could imagine a world in which we get to see sort of some fruits of the effort of the voluntary program. I think there are always sort of actors with good intentions and actors who are, willing to go the extra mile to get their intentions to become reality. And some of those who will say, well, we tried, but, it was too hard or something like that, and throw up their hands. the federal government always does have additional regulatory enforcement and rulemaking options. So, and we know that, you know, CMS 0057F goes into effect in 2027. I mean, to the extent that prior authorization is so incredibly burdensome on practices, I think here we actually have a sort of customer demand potential for the more widespread deployment of the, you know, the full functionality, Stephen, because people, you know, it will get spoiled on that, and they will refuse to go back, and they will be willing to pay for something that provides such a substantial reduction in sort of zero value add administrative time and effort. And I know in my practice, I the majority of the time, I would say, have to bring a patient back for at least one encounter to resolve some of these prior authorization problems, because my shared decision making is no longer valid if my decision is not upheld by the insurance company. And having not discussed a bunch of options, contingencies with the patient, knowing what my options were, there's no other way for us to do that in a shared way without having another visit. And that's a real source of waste too. I like to think that, you know, everyone who's ending up paying for that useless visit, which is also resulting in a delay in treatment, would, you know, do their best to really get this out of our workflow.
Thank you for that comment. So let's go ahead and dive into some of the questions that I've queued up for you today to do a round robin fireside chat with both both the two of you, and hope that while we're doing that, we'll get some additional questions that will come in from the audience. So let's talk a little bit. Let's first start with the barriers, and then I'll do some advancing adoption. And as Stephen noted, you know, the body of work for the CAC is really helping us identify the current obstacles and the opportunities, and that those obstacles are something that we collectively are really going to need to address as a community to really get the bang for the buck. And so, can you provide an overview of the most significant barriers facing healthcare providers today, especially in the context of adopting new technologies? I'm not sure which of you would like to go first. Maybe Stephen, do you want to start on this?
Yeah, I'd be happy to start. I think you know, when I talked about kind of there's a reason that low resources was the first set of category of barriers that we talked about from the CAC. I think that is one of the fundamental challenges that's going to be a little bit more difficult to do, because it's not the simple kind of, oh, I'm just going to go to an app store and download an app, and then it's available and I can use it and I know what to use. It's a little more complicated than that still. So I think that's a big barrier. And then I think the other big barrier that I would put up there is kind of just awareness. So I think people just don't know what they can ask for. So they don't know exactly what to ask for from their EMR vendor, as an example, and they don't know what to kind of expect, kind of where is the market relative to these adoptions. So I think those are probably, from my perspective, which is you know, not everybody, but at least from a primary care perspective, I hear those two things as probably the most important. But
And on the EHR side of it, I would also think not only what can the EHR do for you, but also the reasonable expectations around how far that EHR vendor, in providing a technical capability, can actually help you with modifying your own workflow and figuring out the nits and the gnats. I would think that that's a part of that conversation as well.
yeah, absolutely. I mean, Julie mentioned that on kind of the beginning of kind of that clinical workflow, you know, so not only does it kind of exchange the data on the back end, but what's that kind of clinician workflow that makes it easy for them to do that. And I think the other thing too, to give a little bit of some additional credit to the EMR companies, docs don't know who's supposed to be implementing these things. So maybe the EMR has the capability, but none of the payers that particular organizations work with has that. So it's not. And then the EMR did a great thing of saying, like, well, let's just not show an extra button on something you can do that you can't do because nobody's there. So they were even thoughtful to even go the step further than what was required. So again, I don't want to push and say, oh, this is just an EMR problem, but I do think a lot of our docs are going to be completely dependent upon how the EMR is able to help support them and getting this type of capability into their practice.
Yeah, I will definitely reinforce, as the previous CMIO of the National Association of Community Health Centers, FQHCs have struggled historically with all of their technology costs and challenges. It's very difficult, on really thin margins to hire technical experts in a, competitive job market. It's hard to retain those people when you can hire them to begin with. It's hard to plug in new technologies into older systems, which they're more likely to have. They often get the upgrades much later than some of the other large commercial or academic customers. So usually, there's a technology debt and loss in those kinds of organizations. I'll say another potential barrier is processing time. I know some of the early pilots have been successful in, skipping around this, but if you think about a rural practice that may have more challenges with bandwidth, how much time it takes to do these exchanges and that computing power may, be a potential barrier in some places. I also have, some ongoing concerns about not about the plan's abilities to generate these requirements, but because of the complexity of some of this decision making, how they'll effectively package those requirements into the documents in a way that it can actually interact with structured data in the electronic health record. Right now in the manual process with prior auth, I frequently get like a sentence that I'm supposed to answer on like a piece of paper and fax it back to them. So how effectively will the EHR be able to scan for that information if it's likely to be, say, in a history of present illness, part of an unstructured note? So I foresee a number of those challenges where you have documented something and the system will ask you to redocument it, where the coverage requirements document is not appropriately, or discovery is not appropriately formulated. And so there are gaps or denials, even when it seemed like the process was successful.
Yeah, and I think that there's sort of this also legacy environment of you getting response messages, and sometimes those can be highly generic when we look at our, CARC and WARC codes that may be used, that isn't necessarily tied to FHIR, but it's the way our our information systems have been built out over the years, and people have had some variability in what kind of messaging they pick to send back, and how can that be fully interpreted? Because sometimes it's not easy as a human to know exactly what that meant. And I recently heard an example where someone said that they made a prior authorization request. They got a response saying no prior authorization required, but the reality was the procedure wasn't even covered under the plan. So it should have been not covered service.
Yeah.
And so they thought, oh, no prior auth, go ahead and do it. And then there's a whole bunch of patient liability happening.
Wow.
Yeah. So I think
I
that we're
do
going to,
think that one thing that could be exciting is if, the trebuchet option, is executed through Smart on Fire, it may actually lead some of, greater use of specialty specific content, of additional functionality, bells and whistles that'll be helpful to practices via that Smart on Fire marketplace. I think there's still been relatively low adoption of that. And I think once people say, oh, like this is really great, it works from the interface and it does the thing I want to echo your point with all of the plans I am actually working with, that will potentially catalyze more of this kind of service approach.
Yeah, I think there's also something you said earlier about like in workflow dynamics, and there will be choices by providers as to whether or not provider offices, I'm going to call it generically, whether the doctor or the PA deals with it in the workflow at that moment, or if it's given to support staff to help advance that patient's scheduling of the ordered service. And so I think that we're going to learn things as we're doing this, and we're going to have more opportunities to further enhance those implementation guides. And it's part of the reason why Da Vinci and the feds have also been very keen to recommend, not require, because we really have learned from the past experiences of getting that real world usage to really inform a mature set of specifications that transform software into capabilities. So going from that topic, I'd like to talk a little bit about something we started to tiptoe into, and I want to dive deeper into it about how these barriers affect patient care and contribute to health inequities. And Julie, I think why don't you kick this one off because I think you started to tiptoe into those waters earlier, and maybe you can expand upon this, and that really it's not just about the inequities, the lower resourced rural providers, but also those greater patient care and health inequities.
Yeah, I mean, I think, we're already struggling through a period where there's a lot of sort of lack of trust and confidence in healthcare, health information. And these processes are actually part of that, right? When you pay for health insurance and get that coverage, and then you go to the provider they're recommending, and then you can't get the services that your doctor's saying you need, it's very demoralizing. And I do find
Okay, okay, that's Julia freezing.
Great.
Okay. All right,
Yeah.
Julia, you froze up. Okay, well, she gets her sister. Oh,
am I back?
you are back. Awesome.
Yeah, but it's also increasing the cost of care. It's making worse outcomes. People go to the ER, their pain is not addressed, or their blood pressure is out of control. Um, and people can actually suffer harm, right? Like, it took me 3.5 weeks to get a prior auth done on a patient. I wanted 2 weeks of a glucose monitor on because it looked like she was having periods of hypoglycemia. Well, in that 3 weeks, you could have gone into a hypoglycemic coma. Like, every time we, insert these processes that disrupt the care relationship and the what little coordinated care process there already is, we're just, undermining people's confidence. We're adding to burnout of clinicians. We're adding to the overall cost of the system, and we're putting people at risk.
Yeah. And Julie, when you talked about, having that second appointment, just think about people that have transportation issues or have problems getting off work. So they may decide just not to come back or can't come back for that second visit for some of those issues. And those are those with the more, vulnerable populations from a socioeconomic status. So, yeah, I think it is a big issue.
Yeah, and I will say, for some of the patients where I'm like, oh, like this person's not going to come back, or my blind patient who has no car, like I'm not going to ask her to come back in. So what I'll do, I'll call them and spend 15 minutes not getting paid. And for the health center, I'm still cutting in and out, aren't I?
No, you're good. You've actually
For the
maintained.
health center, like their margin is already razor thin. So me doing unreimbursed activity is putting the whole place in jeopardy as well. And the amount of that unreimbursed activity, because we have full-time staff people just processing these prior authorizations, is like, it threatens even everyone's access and not just the people involved in the prior auth.
Hmm. So let's talk a little bit more about that impact on manual processes. And so, Julia, I know that you're actively practicing these days, and so I think maybe you have maybe some additional comments, or maybe not. Maybe I know you've kind of woven in some of the perspectives that you shared with me earlier, but from a manual process perspective, the are there other aspects beyond the implications that you've already stated that you'd like to share?
Yeah, I mean, that staffing challenge I spoke about with technology equally lends itself to the manual people who are doing these tasks, right? Part of the reason that glucose sensor took me 3.5 weeks instead of maybe 2.5 weeks was one of those weeks a person who does prior auth processing was on vacation. And so the request sort of fell into a hole for a week and then resurfaced afterwards. And if that person just quit tomorrow, I don't know how we would, how we would overcome that in a short period of time. Probably what would happen would be the person who remains and the pharmacists who work there are going to take on more of that burden. The processing time will go back up, and it will be really challenging for everyone to get those things done. And it is just so frustrating to find out after the fact that if only you knew that the medicine was this one and not this one that they would pay for, you could have ordered that, but you don't know. And so it's just like all the time you're doing your best to like participate in making a decision with the patient that you think is the best for them. And then the patient, you have to come back and tell the patient, oh no, we thought that was the best thing, but you can't have it. And then the patient is even a little suspicious of the replacement treatment, right? They're like, well, is this really as good as the one I was supposed to get?
Yeah, I've been there. I've questioned the same thing. Um, so Stephen, do you have anything on that one, or are you okay if I move on to ask the final section question in the barriers? I'm going to actually combine two of the questions about, talking about how providers can advocate for more funding to support technology upgrades, or what maybe the lower resource organizations could do to maximize their path towards technology improvement. So any lessons learned about how providers can advocate to get better tools and supports?
Yeah, so I think two ways. So one is outside your organization, the other is inside your organization. So from an external perspective, I think again working with your professional societies, and I participate in meetings with a lot of different specialty societies. All are understanding the issue around prior authorization, as an example, and some of the other data exchanges that we talked about are needed. So reach out to your organization so that you can give them real world examples, and especially if you're in a constituency that from a Congress or that is thinking about this type of stuff, they would be great to know that what's going on and could be the person that talks with the your local congressperson to understand that. So I think that's one thing from an external side. On the internal side, I think that's where there's an opportunity, I think, for kind of education, is being able to provide those frontline clinicians an understanding of where things are at, what can be done, and what that impact is, so then they can internally advocate for themselves inside their organization to go to the CMO and say, look, this is killing us, but also here's a case study from Sutter. Let's say pick Sutter Health as an example, where they were able to save X number of tens of thousands of dollars because they were able to implement these IGs, and this was the impact they have. So I think there's an opportunity there to provide them with that education, and then they can do that kind of the advocacy inside their organization. I think those are the two things. And then the other is, last thing I say is just ask your EMR. And if you have a really good contact with the EMR, and just let them know that you're kind of giving that demand side signal that this is important to you and important to your other providers in your practice.
Anything you'd like to add on that, Julia?
Yeah, I would say I strongly agree with reaching out to your societies. The HIMSS chapter in your local area may also be helpful, because other folks in that group would probably be somewhat knowledgeable about the technology options that are available locally, but also the payer participation in the region in supporting that option of electronic prior authorization.
Mm.
Um, and I think, having a open relationship with your IT department or informatics department, and sort of keeping them abreast of these things early and encouraging them to also advocate to clinical leadership is important, because they'll be the ones who have to do some due diligence to make sure a solution is going to be successful. And if they start on that earlier, it'll make that pathway to deploying more smooth.
Yeah, so let's go ahead and pivot into advancing adoption related questions. And let's start out with how organizations can foster the interest in the FHIR APIs. It seems like a natural extension from what we were just talking about. How we can foster interest in the FHIR APIs and the Da Vinci implementation guides across the practices. So, building on this idea, Julia, that you just said of like early and often collaborate with your IT folks, elevating, a common need. I think is part of the equation. I also think that there's something that I'd like to dive into deeper as I give you both the chance to respond to this, is the aspect of dependable ROI that Stephen mentioned, I don't know, maybe about an hour ago or less, about that. That's something that providers really want to have, something that they can really rely upon. So can you talk a little bit about your view on fostering interest? Either one can go first.
Sure, I'll jump in. I mean, I can say that this is not really a particularly hard sell from a user perspective because the user experience here is terrible. So I think if you could get someone excited and bought in the idea that, we could take a lot of the steps and a lot of the time out of this process in the place that we're already working, that you're going to have a lot of buy-in, like there'll be excitement and helping to ensure that solutions that people deploy are in fact usable and workflow friendly is pretty important because we don't want to turn people off of something that's an exciting and good idea. And I like Stephen's comment sort of alluded to, like, show people the success that others are having and make them sort of jealous for, getting some of those efficiencies and reducing the burden on patients and the care team members.
I like that.
Yeah.
Stephen, would you like to?
Yeah, I would agree with those comments. I think that makes a lot of sense. I don't know that I have a whole lot to add to that.
So from a dependable ROI perspective, I kind of struggle with this because everybody wants some ROI, and that we've seen some great, stats from especially the Multi-Care and Regents HIPAA exception report, which has been broadly socialized, and the value that they were able to demonstrate from that. And doing a cost benefit analysis was not necessarily an easy task for us that worked on that report. And so I think about that experience and how each organization makes architectural and in technology investment decisions, how those expand over time. So like I'm thinking that there's something around dependable ROI for providers that they can rely on and being able to like manage that effectively. And are you aware of any models out there that might help us understand what those proof points are that they feel are reliable?
I don't know of any models that are out there. I think to your point of the variability inside of each provider organization, dependable kind of becomes a little bit more challenging. I think what you could do is provide a standard measure set. Again, kind of what we talked about in the CAC is at least say like, here's how you should be able to measure these. And then I think you give those case examples of here's an organization that did this. And if you provide enough information, or at least one of my mantras over the last 20 years and helping docs adopt technology is if they can find a physician like them and a practice like theirs that's been successful, then they're more likely to think about, oh, if Dr. Waldren can do that, I can do that. So they have the confidence, but they also then see that there's a real world example of success. And they also have somebody they can maybe even reach out to and say, hey, I have a question or something like that. I think those are things we could do as opposed to, I mean, it'd be great to be able to say, here's a Google spreadsheet that you can download and put your numbers in. It'll tell you exactly how many thousands of dollars you'll save, but I don't know that we get there.
Yeah, and I think, I'm a big fan of evidence-based process in addition to evidence-based medicine.
Yeah.
And so if we're to go about just throwing these things at our existing process without thinking about how to measure and understand impact, we're probably sort of rushing into it. I think if you aren't already tracking your prior authorization volumes and processing time, you should start doing that right now. And then you will be able to see what is the impact on volume, processing time, denial rates, every one of those pieces of metadata that, will tell us about the success of a specific electronic prior authorization solution and approach, as well as potentially help us to know about unintended consequences. If you see that the processing time is halved and the volume starts going up exponentially after that, then you have to start wondering, like, do I need to talk to CMS? Do I need to talk to my payer and show them this data? Because a bright light is a very good sanitizer and problem solver. If we're not actually tracking any of those data, we actually probably won't notice. We'll feel like this solution is not working for us, only to find out that we're actually doing twice as many prior auths now as we were in the same amount of time. And I would extend that to, the user experience, because, burnout is really important for us. And if people are finding that this is something that makes them slightly less likely to want to quit working in this, like that has actually a dollar amount to it, right?
Yeah.
Turnover in healthcare is extremely expensive. Recruiting people, training people, retaining people, benefits, all of those things. You can put an actual dollar amount to saying like, I'm 5% less likely to quit. That's actually worth something, right?
Yeah.
That may be another person you don't have to replace.
Yes, and you lose a lot of time and productivity in getting someone up to speed. And so, but one of the things that a question that came in from an attendee is, what is the first thing that comes to mind that this one PA resource could do rather than doing PAs all day in your practice? So I'm thinking it's very germane to this conversation, because if you can say, oh, if we can automate this and we can reduce the need to pursue prior authorizations 3/4 of the time, we'll have somebody who could actually be able to work on something else as a clinician. What comes to mind that's a better use for those folks?
Like the actual staff who are involved in the PA.
Yeah.
Oh,
If you could,
I have a wish list of items. Um,
okay.
but this directly relates to the success of automating prior authorization, which is focusing more on data quality. And we have such a data quality problem in healthcare. But data reuse is the answer to a lot of our administrative low value activities, right? Our reporting of quality measures that accurately reflect the care that we provide, reporting of public health information, our ability to succeed in value-based care arrangements, our ability to get the right amount of reimbursement on claims, our ability to risk adjust, our ability to do follow-up on things like referrals and gaps in care. All of those things are dependent on good data, and so is electronic prior authorization, because one of the steps in the EPA chain is that the machine hand reaches in and tries to suck back all of the information that's needed to satisfy the coverage requirement. And if that information is not appropriately documented in the place in the record that that hand will look to suck it out, all of those fields will populate as empty, and it will not be an automated process. It'll be a manual process done in the electronic interface. And so having those resources reassigned to systematically fixing some of our data quality problems will yield many times the benefit, not just to EPA, and probably they might start at EPA, but thinking about even, does there need to be a field that describes X? Because it's a frequently seen question in coverage requirements, but there is no structured place to put it, and therefore it's difficult to pull that back out. And being a person who helps to train NLP to be involved in pulling unstructured data out to feed the coverage requirement is another better use of their time still, right? That will still help us with data quality. It'll still help us with all those data reuse cases. So that would be my wish.
Very nice. I'm gonna move on unless Stephen, did you want to chime in there or? You're
No,
good.
I think there's more work than can be done, like in primary care. So if you have them not doing something, there's a laundry list of other opportunities that they could be working on that have more clinical value.
Yeah, I so very agree. And so let's talk a little bit about the key factors in establishing a successful working relationship with payers, and that includes trust. So what thoughts do you have on those key factors for establishing that effective working relationship? Do you want to start out, Stephen, with this one?
Sure, sure. So I think one of the important things is have a clear data use policy, so that both clinicians and provider organizations and the payers all understand how the data is going to be accessed and how it's going to be used. And I think that would gives a lot of trust, and then also provides, a requirement now. So, there's no requirement as long as you abide by HIPAA, which means treatment, payment, and operations. If you get access to any data from an EMR from one of our practices, you can use that as a payer because you're a covered entity however you want for that TPO. But I think if you have a policy that says this is how we're going to use it, this is how we're not going to use it, you now have said definitively to educate the prioritization, but also you've legally bind yourself to support that policy. And I think that would help a lot with trust. And the other thing I think too is just an ongoing dialogue between your payers and the providers so that you start to actually trust individuals inside the organization and understand that are you trying to row for the same sorry, I was about to mix my metaphor and say row to the North Star, and that doesn't work. But you're all rowing in the same direction. Then that gives you a little bit more trust as well. But I don't know. Julia, what do you think?
Well, I think, just the transparency of finally knowing what those coverage requirements are is a good step in the direction of trust. I think hopefully the activity of having to structure those requirements may lead some payers to think, is this too complicated? Can I make it simpler and easier for practices? Have I looked at whether or not this prior authorization is actually yielding any difference in appropriateness of care, outcomes, or costs? Because I would guess many of these do not. Is there a way to also give better information to patients about prior authorization? Because I definitely have felt many times blamed for the thing that I didn't want to do myself. But I think actually an interesting thought, if we're thinking of the payer as a partner, there is a flip side to Stephen's note about our data going to the payer, which is if the payer provides us with an effective stream of data, it will be easily reusable to help us provide better care. If the patient has not gotten breast cancer screening in my EHR, it doesn't mean that they have not gotten a mammogram at an outside facility and no one sent me the stupid report, which happens all the time. If I
Yeah.
have the claim, then I know exactly where and when that thing happened. I can get that information and my quality score will go up. And I won't call the patient and ask them to get a mammogram that they just got because it happens, right? So I think encouraging the payer to use their care coordination resources that they're paying for at the payer to actually work with the office and offload maybe some of those activities onto the payer. They are paying people to be care coordinators and to also share that data that will help us to do care coordination but more effectively on our end is a great way to sort of bring that partnership together.
Well, it's interesting that some of the questions that have been coming in on the Q&A are very much aligned with some of the topics that I had queued up for you today. And I want to ask this one, which could be a little bit of a loaded gun, but let's ask it anyway. Do you have concerns that payers will adopt solutions as more of a check the box versus investing in choosing solutions that might provide a better response to the provider?
So I will say, I think this is one of the valuable reasons to do a good job of planning how you will gather information about the success or not of your electronic prior authorization process. Because if you're seeing that denial rates are going up and not down, or that the processing time is not substantively aided by the electronic process, I think that strongly suggests that you have a check the box process, which is not very effective. And so you can take that data as ammunition and sort of turn around and say, you haven't effectively achieved the implementation as designed, because it should not yield the same time. It should not yield, the same denial rate, because now I'm proactively responding to those questions without extra process steps.
Yeah. And I always say too, I don't think, I think the number of actors that are going to be malicious in that kind of piece is extremely small, both from a vendor or payer community. But I think the big challenges is one, as Julia laid out, that you're just not aware that you're creating a check the box thing because you're not actually measuring to know that your system is working well, and or you did not seek a lot of provider input early in the process so that you knew how they would use that, or it would be valuable to them. My other big concern, and one of the things I liked about the notion that the AHIP and CMS did the voluntary one, is that if you have this hard deadline of a requirement in the federal regulation to meet, then you're going to meet that deadline. And to do that, you're going to do what's the letter of the law, not what's the intent of the law, right? Because you're going to have all sorts of other stuff that you got to do resource-wise to get it get accomplished. And many times it's, these regs are trying to push the envelope too. So we saw that with meaningful use, right? So that many times we had to stop and change the regs before they actually became active because people couldn't meet those. So again, I think it's that notion of just not aware, as Julia laid out, or that there's some kind of external deadline that's pushing you to do this. And in that case, you either don't have the resources to do it well, so you just do it, or you just say like, we don't see that as a value, so we're just going to do what's required, not what should be done.
Yeah, there's so many things that need to be tackled, and it is a part of our culture to expect that we're going to get a federal regulation to move us, and I think that reality is changing. I think that we've been seeing over the years the opportunity for industry to drive more, and the Vinci, as a collaborative of industry stakeholders, is really working on addressing that trust factor by creating more transparency in the data flowing. And we've luckily had good support from our federal partners in pointing to these implementation guides that we're building, and also the implementation guides that actually enable greater trust, not just through transparency, but also knowing which elements the hand is reaching into the EHR for, and that you've got that. I think having some more assurance around the auditing and knowledge and the pre-fetch agreements that are going to happen into the EHRs or to an ancillary repository, sitting aside the EHR, because we know that there's some concerns about performance levels and supporting data needs and API application programming interfaces to support EHI, electronic health information exports. So I think we've got some opportunities to continue to work together with the industry and to further hone not only the data quality that goes into the EHRs, but also the data flowing between the payers and the providers, all alongside those patients having visibility into the process. I feel like we could go for very much more time, and unfortunately, we are at the bottom of the hour. I still have a bunch of questions to ask you, and I really thank the audience for their questions today and attending today's webinar. I thank Stephen and Julia for your ongoing leadership within industry, your role within the Clinical Advisory Council, your roles within HL7 and the Da Vinci Project. Because I think we forgot to note that Julia is also the chair of the board of the HL7 International Organization. So I did note that both of you play various roles in the industry, and we're grateful for your contributions and your leadership. And I think you've given me some creative ideas that I want to talk to Leslie about for some follow-up on work, maybe some videos and some primers to help our provider colleagues be better armed for those engaging conversations with their leadership, technology partners, and payers. So with that, Have a great balance of your day, and we look forward to seeing you. I'm just going to remind everybody, the next Community Roundtable is August 27th. So we'll see you then. Enjoy the month off in July, and we look forward to seeing your survey feedback after today's webinar. Take care, everybody.
Thanks.
Leslie, you're going to need to end the recording because I don't have that control today.
I'm trying.
Okay.
It was not going. It will now. Have a
All
good
right.
evening.